Thank you for joining us for another episode of Doc Talk, where we show how point-of-care ultrasound can rapidly diagnose critical conditions at the bedside and elevate your patient care.
Well, are you ready for a case?
I'm excited to have another case.
Well, this is actually really an interesting case because most people wouldn't think that point-of-care ultrasound would be valuable in this case, especially an EFAST exam, because we always think of EFAST exams for what?
Trauma.
Yeah. Well, EFAST exam is so helpful in cases of abdominal pain, and this is going to be a case that will kind of catch people off guard.
So wait a second. We're going to take the EFAST, right?
Yeah.
Extended focus assessment of sonography for trauma. And we're going to use it in someone who doesn't have trauma?
Yeah.
Why?
Because it gives us the ability to look in the body and answer questions we can't answer otherwise.
And we've talked about this before, but the EFAST is kind of the gateway drug of point-of-care ultrasound. It teaches you how to image the thorax, the heart, and the abdomen.
Yep.
And when you can image into the abdomen, you can look at Morrison's for free fluid, but you can also look at the kidney for hydronephrosis. You can look at the gallbladder. And that's really the value of learning an exam maybe that you won't need in the clinic.
Well, you know, I think it also overcomes some barriers because when you're doing an EFAST exam, you're looking for what? Fluid. You're not trying to look for anything other than that, so you identify anatomy and look for fluid. In the midst of that, you trick your brain into learning the anatomy really well so that you can then adopt other point-of-care ultrasound skills. So somebody says, geez, I know how to do a FAST exam, I'd like to do a renal exam. I go, well, you already know how. All you have to do is now maybe get a short axis view of the kidney and look a little more directed at it. So it's really a tool that helps us to be able to build ultrasound skills very rapidly from.
Yeah. And at the end of the day, it really helps you make better clinical decisions at the bedside. We have talked about this time and time again that the clinical exam is horribly inaccurate. But when you can actually see into the abdomen or into the chest or look at the heart, you can find amazing things.
Well, this case is really going to demonstrate that well, and you're going to be surprised. Why in the heck would we be doing a FAST exam, an EFAST exam, on a 9-year-old whose initial presentation was a sore throat? I mean, really? An EFAST exam? Well, let me give you a little of the background. This little 9-year-old girl develops a sore throat, lasts for about 3 days and goes away. The next day she starts developing abdominal pain. Starts developing some nausea, vomiting, anorexia. This goes on for a day or so, then it gets a little bit better. Then it starts to come back again. She still has a nausea, vomiting, anorexia, and starts to develop some diarrhea. So after this has been going on now for about 4 or 5 days, she goes to the ER and presents with this history. They evaluate her in the emergency department, and she had the sore throat, so they swabbed her throat, and they got a urine on her. The urine showed a high specific gravity and ketones, and guess what? Strep test came back positive. The physician who looked at her thought she had some exudate, so they sent her home on a prescription for amoxicillin. The thing that wasn't ever addressed really was her abdominal pain. Now, I want to clarify, abdominal pain in pediatrics and abdominal tenderness are not the same things. And this girl not only had abdominal pain, she had abdominal tenderness.
Yeah, but I will be honest. I've seen plenty of these kids who show up to the ER. They come in with fever. They get some abdominal pain. You look in their throat. You see the pus. You get the positive strep test. And it's not uncommon for kids with strep to have abdominal discomfort. And I think it's easy to anchor on something like that.
Yeah. Yeah, and I can certainly understand that. The thing is I think we have an obligation to try and explain things too. And I know a lot of people will write off abdominal pain to strep. But abdominal tenderness, that has to raise your antennas a little bit. So they sent her home, and about 3 to 4 hours later, she got worse. And then she presented to the ER, and I actually saw the patient. When I came in the room to see her, I have a 9-year-old who's just laying in the bed, not really doing a lot, looks really dry to me. And so I get this history that we just went over now, and I do my exam. Well, she has real significant abdominal tenderness and pain down in her lower abdomen. So now, let's kind of look at our differential a little bit. So we have somebody who has a sore throat with an exudate who now has abdominal pain, worse in the lower quadrant, but diffuse abdominal pain, some guarding. Is just strep the only thing that can cause that? What about mono? What about a ruptured spontaneous spleen rupture for mono? We've got somebody with abdominal tenderness. Are we going to look and try and answer why?
Yeah, and I think this is where people get into trouble. Anytime you have a bounce back, especially in the emergency department, those people always get another level of evaluation.
Yep.
It's just it's the nature of the business. I think that's where people can definitely get off course, anchor on an initial diagnosis, and try to move people through. So the fact that this is a bounce back patient, you're going to do more.
Yeah.
You're going to be more thorough, maybe some blood work, maybe some other things. And now you're going to do a more expansive evaluation.
So, and that's exactly what we did based on my evaluation. The blood work came back later on, but based on my evaluation, she looked dry. So we started an IV, gave her 20 per kilo fluid bolus, but I also brought her ultrasound machine in. And just so you know, after I already had the diagnosis, her white count came back at 32,000. She had a left shift. Her CRP was 127. She was also a bit dry. Had a little bit of an anion gap. So where did the ultrasound come in handy here? So let's just take a look at it, because we're going to look at a fast exam. We started in the right upper quadrant because that's usually one of the best places to find fluid. And if you look here, you can see her diaphragm here, you can see her kidney fanning back and forth, really looking for fluid, getting all the way out to the tip of the liver. I've actually got more than one view, but we're not going to go through that right now. And then I wanted to look at her left upper quadrant, because really I've seen spontaneous splenic ruptures from people with mono. So I looked at her spleen and measured her spleen. Wasn't particularly large. But as I started looking for her spleen, what I saw up in her in her left upper quadrant is some free fluid here. You can see some bowels floating around right at the tip of the spleen. That's why it's so important to see the tips of the spleen and underneath the diaphragm in patients with abdominal pain in the EFAST exam.
Yeah. So were you expecting that?
I was not, but I was looking for it because I thought she could possibly have something with her spleen. But actually the thing I was really looking for was what was in her pelvis. But I try to kind of follow my protocol just so I don't miss things. Because one of the red flags to me was a girl with abdominal pain, nausea, vomiting, and then starts having little bouts of diarrhea. You know, typical gastroenteritis, they have diarrhea right at the beginning, but developing diarrhea later on says, is there some pelvic irritation?
Yeah. And the other thing I'll do in those two views, because it's E, I will do a sweep definitely of the lung bases. Yeah. Look for low pneumonia, hepatization, just different things that can be very helpful. And you know this, it takes another 30 seconds. I mean, it's just seconds. Yeah. And once you get facile, once you learn how to get these views, and although this had nothing to do with trauma, it all started by learning the EFAST.
Exactly. So let's take a look in her pelvis. What do we see in her pelvis here? Now, this images are a little deep. I do acknowledge that, but here's her bladder. And what's this big thing behind her bladder with the air fluid levels in it there? Or actually the little things of air in there. This is actually a phlegmon from a ruptured appendix, which is what I was most suspicious of, given her abdominal pain, vomiting, gets better, got worse, developed diarrhea.
And I think we see there, you know, the bladder's small, which is not surprising, right? She's bone dry, bone dry. But all of a sudden, you don't have much of a bladder window, but you have something else creating a window, and that should be like, that is not normal.
Yeah, it is not normal. So we'll take another look at it here. We can kind of see as we scan in there that there's really some type of collection right back here behind her bladder. So right at the bedside, I had already ordered the fluid bolus. I ordered antibiotics.
We have some free fluid there too, right?
Yeah.
Up in the upper left there, just a little bit.
Yep. We've got some free fluid down there. I already knew she had free fluid, but we do have some. You can see it right up there as well. So, and actually, you know, when you're looking, you know, a lot of times here's some free fluids you can see actually underneath her bladder here too as well. So this is a transverse view of her bladder, and there's some free fluid there. So one of the things that I've learned over the years looking for appendicitis is a lot of times people say about looking at the target sign, looking for the for a tubular structure that doesn't compress. The first thing I look for is free fluid. Mm-hmm. I look for free fluid down in the right lower quadrant, and typically that's going to show me the appendix if it's an inflamed appendix, especially if it's ruptured.
Yeah. And as we learn how to scan the abdomen, you know, we have a quick approach to get to the appendix and get to that area, so you're in that area and you're looking for the free fluid.
Yeah. So again, now you're able to identify anatomy, so you can look over in the right lower quadrant. So here again is her CAT scan that we have. You can kind of see her bladder and this collection behind there, and these inflammatory changes back here on her CAT scan. If we look here, we can kind of see this collection with air fluid levels as well here. So we gave her antibiotics, we got the CAT scan, she went to the OR and she had a ruptured appendix here. You can see kind of the purulent material here.
And let's stop on that, right? So what do you say here? I got the diagnosis, I gave antibiotics, and then I got a CT scan, because people are like, well, you got a CT scan anyhow, what? So what, big deal, so you used ultrasound.
Well, here's the thing, here's a skinny little 9-year-old. What's your CT scan going to do? Is a radiologist going to let you do it without oral contrast?
Right.
Yeah, or if they do it without oral contrast, you might even miss an appendicitis. So there's a delay of an hour or two to getting antibiotics starting on a kid who's already sick, she's already dehydrated, she's been vomiting, she's got peritonitis just by evidence of having pus. I mean, in this image here, this is another image of just pus all in around her abdomen for that ruptured appendix.
And the thing is, all of a sudden, not, essentially you found a source, you can focus your antibiotic coverage, and you do not delay. Especially in a septic child, getting those antibiotics on early, people die of sepsis.
Yeah.
That's no joke.
Yeah, and one of the things that I'll caution you is a lot of times kids, especially the kids that just lay back and don't move and don't say much or kind of quiet, those are the ones to be the most afraid of. Those are the ones that you have to be the most careful of.
Yeah, great case.
So again, it's just another example of being able to look in the body and use the tools that was initially designed for trauma to actually do an evaluation, initiate rapid care for this patient, and get her to definitive care that she needed.
Mm-hmm. And even going back to the very beginning of that case, to even adding it on at that first presentation with a sore throat, with a little bit of abdominal discomfort, diarrhea, the EFAST exam would have added how much time do you think?
It took me less than 3 minutes to do that study.
It takes longer to get the strep test back.
Yes. As a matter of fact, if you think about it, I was at the bedside, I put the ultrasound transducer and looked at her right upper quadrant, looked at her left upper quadrant, I go, free fluid. I already knew where I was going with this at that point in time.
And so ultrasound helps you help them, and you make these decisions at the bedside, again, making you more accurate in being able to rapidly diagnose these critical conditions at the bedside. So we started out with in the past few months, some great trauma cases, but this is the clinical EFAST. It has all the same values, all the same windows, but you're just using it for things beyond trauma. Yep. And that's the beauty of ultrasound.
Yep. Don't let that tool sit in the corner when it can actually help you make better decisions.
Amen. Dust that thing off, get out there and scan some patients. Know what normal looks like, so when you see the abnormals, the diagnosis becomes easier.
What you just watched isn't just a great case, it's a game changer for acute care heroes like you. HQ MedEd, the pioneers in POCUS, who literally wrote the book on point-of-care ultrasound. We deliver unmatched educational expertise. Don't miss your chance to level up. Join us May 16th for our point-of-care ultrasound course. Head to hqmeded.com now to secure your spot and transform your practice.